All right, let's dive in. Today we are talking about one of the most fundamental skills in all of medicine, the cardiovascular physical exam. It's this incredible blend of knowledge, sharp observation, and, the simple power of touch to figure out what's going on with a patient, right there at the bedside.
But here's the thing. We have to be honest with ourselves. As this quote points out, these essential skills, well, they're kind of fading. And it makes sense, right? In a world with so much amazing technology, it's just so easy to go straight for an imaging study, even when a really good exam might tell you it's not even necessary. So that leads us to the big question for today's explainer. In this age of high-tech scans, what's the real power of the physical exam? I mean, what can a skilled clinician figure out before a single machine is ever turned on? Well, let's find out. Okay, so first things first, let's talk about why this exam is actually more important than ever. This isn't just about tradition. We're talking about gathering real, hard data that can literally change patient outcomes, all while building that crucial bond between a clinician and their patient. And look, the proof is right there in the pudding. A solid bedside exam gives you absolutely invaluable information. For example, if you have a patient with heart failure, seeing an elevated jugular venous pressure can actually tell you more about their prognosis than some of their initial lab work. So this isn't just about going through the motions. It's smart, efficient, evidence-based medicine that helps us decide what to do next right away. The exam really kicks off the moment you walk into the room. Inspection isn't just a passive glance, it's an active hunt for clues. And honestly, it's amazing what the body tells you before you ever even lay a hand on the patient. And a fantastic place to start that search is at the periphery. Seriously, the hands and feet can be a literal roadmap to what's going on with the heart.
And what's so incredible is just how specific these clues can be. Finding tiny little splinter hemorrhages under the fingernails, that could be one of the very first signs of a serious heart infection like endocarditis. Or seeing pitting edema in the legs, that's just a classic sign of volume overload from heart failure.
Now, let's zoom out a bit. The patient's skin and their facial features offer a whole other layer of diagnostic clues that you really don't want to miss. So here, we're looking for things like cyanosis, that bluish tint, and figuring out if it's central, like on the tongue, versus peripheral is totally key to narrowing down the problem. Even something that seems subtle, like a high-arched palate, can be a major tip-off for Marfan syndrome, a condition that puts the aorta at serious risk.
So after we look, we touch. Palpation is where our hands get to feel the direct, physical results of the heart's work. Everything from the quality of the pulse in the neck, all the way to the actual impulse of the heart beating against the chest wall.
Let's talk about an absolute classic finding: pulsus parvus et tardus. It sounds fancy, but it just means when you feel the carotid pulse in the neck, it feels weak and it's slow to rise. This is a hallmark sign, a huge red flag that points directly towards severe aortic stenosis, because the blood is just struggling to get through that super narrowed valve.
Now, the feel of the apex beat itself, the point of maximal impulse, man, it tells you so much. When the heart is under pressure overload, like with aortic stenosis, the impulse feels sustained. It's like it's pushing against your fingers for just a little too long. Now compare that to volume overload from something like mitral regurgitation, where the ventricle gets bigger. That causes the apex beat to feel enlarged and to shift downward and out to the left.
Okay, this next one, pulsus paradoxus, sounds a bit complicated, but it is a huge deal. It's when the blood pressure drops more than it should when someone breathes in. And while you can see it in a few conditions, the one you absolutely cannot miss is pericardial tamponade. That's when fluid builds up around the heart and squeezes it. Finding this can literally be a life-saving clue.
And finally, a thrill. It is exactly what it sounds like. It's a heart murmur that is so loud and turbulent that you can actually feel it vibrating through the chest wall. It's pretty wild. And if you feel a thrill, you've already confirmed that the murmur is significant. We're talking at least a grade 4 out of 6.
All right, it's time for the main event. The part of the exam that gets all the attention, auscultation. This is where we put on the stethoscope and listen to the symphony of the heart, learning to pick out the normal rhythms from the sounds of trouble.
So let's start with the absolute basics. You've got S1, the lub. That's the sound of the mitral and tricuspid valves slamming shut at the start of systole. Then you have S2, the dub. That's the aortic and pulmonic valves closing at the end of systole. Pretty much everything else we hear is timed against those two fundamental sounds.
Now S2, that second heart sound, can get pretty interesting. It can actually split into its two parts, the aortic and pulmonic sounds.
Normally, that split gets a little wider when you breathe in, but, and this is a big but, if you hear that split getting narrower when they breathe in, that's called a paradoxical split. And that's a big red flag for something being wrong, like a left bundle branch block.
Beyond S1 and S2, we're on the lookout for extra sounds. Hearing an S3 gallop in an older adult is an incredibly specific sign for heart failure. Another really key sound is an opening snap. It's this high-pitched sound right after S2, and it's the classic calling card of a tight stenotic mitral valve.
So, how do you tell all these different systolic murmurs apart? Well, it really comes down to their timing, their shape, and how they respond to certain maneuvers. For example, the murmur of aortic stenosis famously radiates up to the neck, but the murmur of HOCM has this really unique party trick. It's one of the only murmurs that gets louder when the patient bears down. That one finding can be the key to the entire diagnosis.
Diastolic murmurs are a bit less common, but here is a super important rule of thumb. They are always abnormal. A diastolic murmur is never innocent. The trick is to distinguish the high-pitched blowing sound of aortic regurgitation right after S2 from the low-pitched rumbling sound of mitral stenosis that you hear a little later.
Okay, so we've looked, we've felt, and we've listened. Now comes the most important step of all, taking all those little clues and weaving them together into one coherent story.
And this is where that classic, systematic approach really shines. Inspection, palpation, percussion, which, to be fair, we rely on a little less these days with imaging, and auscultation. Following these steps, in this order, creates a ridiculously powerful diagnostic algorithm that you can do anywhere, anytime.
And that really brings us full circle. The physical exam isn't just some old-fashioned ritual. It is an irreplaceable diagnostic tool. It shapes our thinking, it helps us choose the right tests, and it can even help predict how our patients will do. It's the foundation that all of our modern technology is built upon.
So I'll just leave you with this thought. Technology is an incredible ally, no doubt about it. But it can't replace the critical thinking, the synthesis, and the pure human connection of a physical exam. The real art of medicine today isn't about choosing one over the other. It's about mastering both.